So first we'll talk about rhegmatogenous retinal detachment. You can see this picture here. The patient has very clearly a retinal break. This is a retinal break. You can see the outline of the break very clearly. So this rhegmatogenous retinal detachment, usually vitreoretinal traction is not one of the most important things we need to consider, but we have to consider this as an important factor. That is, there can be liquefied vitreous gel within the subretinal space, and this can aid in separation of neurosensory retina from the RPE layer. Now, how does this vitreous gel get access into the subretinal space in a rhegmatogenous retinal detachment? That is a question. This detachment can be total when it involves the entire retina, subtotal when a sphere or hemisphere is involved, and subclinical when there is a small amount of pooling of subretinal fluid which is more than 1 disc diameter from the break but less than 2 disc diameter from the equator. So, it is smaller area that is involved. The pathophysiology is that the outer pigment epithelial layer, the RPE layer, and the inner neurosensory retina have a potential space. Now, normally this space remains firmly closed. In all of us, the space remains firmly closed. It remains firmly closed because of certain forces of attachment. So, what are these forces of attachment? One is, it is due to the hydrostatic mechanisms, and the other is interphotoreceptor matrix. So, when you say hydrostatic forces of attachment, we are talking about two things. One is, it can be because there is a very good RPE pump mechanism which is keeping it opposed, and the second is because these patients can have an osmotic gradient. This osmotic gradient regulates fluid and hence it keeps it opposed. So, these factors aid in keeping the retinal layers opposed without allowing fluid to accumulate in the potential space which is called subretinal space. Now, forces of detachment can be, the most important force can be traction, that is vitreoretinal traction. This is one of the most important forces of detachment. So, what are the risk factors? Patients with retinal detachment, most common risk factor is trauma or myopia. They can also have it in hereditary vitreoretinopathy, that is, something is genetically determined, some genetically determined disease is causing a constant problem in the vitreoretinal interface, and common causes of this can be familial exudative vitreoretinopathy, congenital retinoschisis, all these can be causes. Inflammations such as any inflammation that is going to cause activity in the vitreous hemorrhage, vitritis can be a risk factor for the development of retinal detachment. Even vitreous hemorrhage can be by itself can be a risk factor. Cataract surgery, when there has been lot of vitreous manipulation during cataract surgery, if there has been a posterior capsular rent followed by vitreous loss, and any manipulation of thus can lead to predisposed to a retinal detachment. And we have a very important term which is called peripheral retinal degeneration. So, peripheral retinal degeneration is one of the anatomical predisposing factors for rhegmatogenous retinal detachment. So, pathogenesis per se is, there is an age-related liquefaction. So, this is the pathogenesis of rhegmatogenous retinal detachment. So, there is an age-related liquefaction of vitreous gel. So, I told you at the beginning of the class that the vitreous is a gel-like structure, but over time and with age, there can be a liquefaction of this gel. So, it will become like a fluid. Now, this fluid, suppose the posterior cortex of the vitreous is made up of posterior cortex. So, if this posterior cortex develops a hole due to degenerative changes, then there is a place for this fluid to pass through from the vitreous cavity, and when this vitreous fluid passes through, it can cause a separation from of the internal limiting membrane from the posterior vitreous. So, the first place is, it passes through the posterior vitreous. So, the first step is, it is passing from the vitreous, if this is the retina and this is the vitreous, its first step is, it's passing from the vitreous into this space. So, it's detaching the vitreous, posterior vitreous from the internal limiting membrane. So, this is creating a potential space. So, this fluid from these pockets will pass through a hole in the posterior hilar, separate the ILM from, separating it from ILM, and it is called a posterior vitreous detachment. This process results in a posterior vitreous detachment. So, this detachment can sometimes be incomplete when it can cause flashes. So, when it is incomplete, when something is pulling on the retina, if it is completely pulled, there is no problem, but if it is partially pulled, it can cause flashes, and floaters can mean there is some derangement of vitreous clarity.